When doctors are surveyed about how they want to die, the results are striking and they almost never match the kind of death that most people in hospitals actually receive. Physicians overwhelmingly say they would want less intervention, not more. They would want to be kept comfortable. They would want to die at home if possible. They would not want CPR if their heart stopped in the context of a terminal illness. They would not want to be placed on a mechanical ventilator to extend life by days or weeks when recovery was not possible. They have seen what that looks like from the inside, and most of them do not want it for themselves. The gap between how doctors want to die and how their patients die reveals something important about what happens in hospitals when serious illness meets a system that defaults to treatment. CPR, as portrayed in popular culture, bears almost no resemblance to CPR in reality. On television, patients are resuscitated and walk out of the hospital. In reality, for elderly patients with serious underlying illness, survival to discharge after in-hospital CPR is often below 20%. Many patients who survive CPR in that context have broken ribs from chest compressions. They may spend their final days on ventilators, unable to speak or say goodbye. They may die in an ICU rather than with the people they love. Research has consistently shown that patients with terminal cancer who choose palliative care focused on comfort rather than aggressive treatment do not die sooner. Some studies have found they live longer. They also report better quality of life in their final months. They are more likely to die in a setting of their choosing. They are more likely to have meaningful final conversations. The barriers to this kind of death are not medical. They are systemic and cultural. Families feel that asking for less treatment means abandoning someone they love. Doctors fear legal liability for not doing everything possible. Hospitals are financially incentivized to provide more care rather than less. The conversation about what a person actually wants at the end of their life is one of the most important conversations in medicine. Studies show it happens far too rarely and far too late.